This is part of a cardiac CT examination on a 61-year-old male patient. Depending on the protocol, a non-enhanced CT may be obtained before obtaining the contrast-enhanced CT cornea angiogram. One of the reasons to obtain this is to assess for the presence of calcified coronary plaques. As you see here, there is a calcified plaque in the coronary artery on this study that's performed without contrast. That's why if this is performed in a specific way, it's usually called a coronary calcium scoring CT. Without obscuring intravenous contrast on board, you could calculate the amount of calcium in the coronary arterial system, which gives you a hint about the patient's risk of having events from coronary arterial disease. The contrast part of the examination is called a coronary CT angiogram. You could see how you could nicely see the coronary arteries after IV contrast enhancement. Compare this appearance to the calcium score CT. The reason I'm showing this case is not for the coronary part of it, it's for an extracardiac finding. Although the finding that we're going to discuss here is a basic finding and it's good for juniors, seniors would benefit from this as well. So the finding I want to show here is seen on the calcium scoring non-enhanced part of the exam. There are mildly enlarged mediastinal lymph nodes, as seen in the subcarinal group here. Bilateral hilar lymph nodes as well, such as those here. Here are calcified lymph nodes in the other hilum. A few other lymph nodes are also seen elsewhere, here in the posterior mediastinum adjacent to the esophagus. And small lymph nodes seen above the diaphragm known as epiphrenic lymph nodes. The more interesting part of this case is that these lymph nodes have internal calcifications. As you see in the subcarinal lymph node here, there is central calcification, which is heterogeneous and smudgy in appearance. Note how calcium is similar in density to the bone here. This is part of the spine. So the main finding here is the presence of multiple mediastinal and bilateral hilar, mildly enlarged calcified lymph nodes. This is the main reason I'm showing you the case for. We're going to discuss the differential diagnosis of calcific intrathoracic lymph nodes. The first category for this differential diagnosis is that of granulomatous disease, which could be due to an infection or other cause. When it comes to infection, the commonest reason worldwide would be previous tuberculosis. Fungal infections such as histoplasmosis are also common in some regions of the world. Other categories that are not due to an infection and that could be granulomatous should be considered. The classic entity would be that of sarcoid. So sarcoid, as we know, is a non-caseating granulomatous disease. Another category to consider would be that of occupational lung disease, also known as pneumoconiosis. The classic occupational lung disease that gives calcification in lymph nodes is silicosis. The other important category to remember is treated lymphoma. Note that lymphoma is typically a homogeneous, non-calcified tumor, but it calcifies after chemotherapy or radiotherapy. Another less common category that gives calcific lymph nodes is that of metastasis. Another rare cause for calcifications within lymph nodes is infiltration by amyloid. Now, let's summarize what we learned from this case. We learned that there is something called a coronary CT angiogram, which is performed to assess the patient for coronary arterial disease. Part of the coronary CT angiogram may involve a first step of performing a study without contrast to assess for calcified plaques, since calcifications may be obscured if you give contrast. This part is called the coronary calcium score. We also learned from this case that not only you could see the coronary arteries, you could see extracardiac findings on a cardiac CT. The extracardiac finding that we see here is a basic finding of calcified intrathoracic lymph nodes. The main differential diagnosis for this finding would be tuberculosis, histoplasmosis, silicosis, sarcoidosis, and treated lymphoma. Other rare etiologies include metastasis to lymph nodes and amyloid deposition. Now, a note for the senior residents: whenever you see this smudgy, ill-defined appearing type of calcification, think about sarcoidosis. Although sarcoidosis would be higher on your list with this appearance, don't exclude the other common entities that we just mentioned. This turned out to be a case of proven sarcoidosis at the end. Now, before we end this case, I will ask you a question, and you could post your answer at the end of the week when we put this clip on the Radiology Bits YouTube channel in the comment section. The question is, what are the primary neoplastic processes that could give you calcific metastasis to lymph nodes? Thanks for watching, and more cases later this week. This is a 72-year-old female patient who presented with weakness. There's this hyperdensity that predominantly involves the left cerebellum and is consistent with an acute hemorrhage. The hemorrhage here is surrounded by a rim of darkness, hypodensity, which is consistent with vasogenic edema. Now, posterior fossa hemorrhage could occur from traumatic or non-traumatic causes. A common cause that leads to this appearance is that of hypertensive hemorrhage. We discussed the common locations of acute hypertensive bleeds in a prior clip. That's something you could go back to on the YouTube channel. The reason I'm showing the case is to talk about the effect of such acute bleed in the posterior fossa and things that you should put in your report. First, see if there is extension of blood into the ventricular system, and this is the case here. You see blood there. So blood extends into the fourth ventricle, cerebral aqueduct, third ventricle, and lateral ventricles. With such a case, you need to comment on the size of the ventricular system. Dilatation of the ventricular system or hydrocephalus could happen due to two reasons in this case. The first reason is because of the compression of the fourth ventricle here, leading to obstructive hydrocephalus. The second reason would be due to clot formation within the ventricles or abnormal resorption of CSF because of blood. In this case, the ventricular size is appropriate for the patient's age and there is no obvious hydrocephalus at the moment. Another thing to comment on is the mass effect exerted by the hemorrhage, and as you see, there are areas of folial effacement. Folia are the CSF-containing sulci of the cerebellum, so they may be compressed by mass effect. The mass effect may displace everything superiorly or inferiorly. If you have inferior displacement of the cerebellum and in particular the cerebellar tonsils, this is called tonsillar herniation. You could suspect tonsillar herniation if you have fullness of the foramen magnum and if you have the tonsils reaching all the way to the tip of the odontoid. In this case, there was no obvious tonsillar herniation. Superior displacement of the cerebellum and the brainstem could be detected by seeing fullness around the CSF spaces here. CSF space surrounding the midbrain is called perimesencephalic cistern. With such bleed, fullness of the perimesencephalic cistern would denote that everything is displaced or herniated upwards. Since the tissue would be crossing the tentorium cerebelli, this would be called ascending transtentorial herniation. Lucky for the patient, none of this is seen, so this patient does not have the worrisome ascending transtentorial herniation signs. The sagittal view seen here is a very good view to assess for herniations upwards and downwards. As you see, the lower portion of the cerebellum, the cerebellar tonsils, do not extend below, so there is no tonsillar herniation. And you could see the CSF spaces above the cerebellum and surrounding the brainstem are not full, so there is no ascending transtentorial herniation. Now let's summarize the points on this very basic, yet very common and important case. First, cerebellar hemorrhage is one of the common hypertensive locations for bleed. Second, whether the bleed is supratentorial or infratentorial, make sure there is no intraventricular extension. Third, if you have a mass lesion in the posterior fossa, assess the status of the fourth ventricle. Along the same lines, see if the patient has hydrocephalus. Finally, make sure that the patient does not have herniation downwards, tonsillar herniation, or upwards, transtentorial herniation. Thanks for watching. More cases later. Since I had several requests from followers, especially junior ones, asking for a little bit of abdominal X-ray reading, I'm presenting this case here to talk about bowel appearance on normal and abnormal abdominal X-rays. Now, assessing bowels on an abdominal X-ray is only one part of the evaluation. You should also assess the soft tissue, bones, abnormal calcifications, and abnormal metallic structures. However, in today's case, let's concentrate on bowels, and then we'll discuss the other points in future clips. You've had time to look at this case, and I'm sure you decided that there are distended bowel loops. Now let's revise a simple point when assessing bowels on abdominal X-rays. There's difference between looking at the supine versus erect films. This here is the supine film while the patient is lying down, and it's good for assessing bowel dilatation. This is an image on the same patient while the patient is standing erect, and it's good for assessing two things. It's the ideal way to look for fluid levels within distended bowel loops, and it's also ideal for looking for free air. This is because air would rise to the non-dependent portions and would make checking for both easier. This patient has dilated bowel loops and fluid levels but does not have free air or pneumoperitoneum. Since free air in the abdomen is an important sign suggestive of perforation, I will dedicate a separate clip for that later. Now back to this erect film on the same patient, you see these multiple straight lines consistent with fluid levels. The patient has bowel dilatation on the supine film, fluid levels on the erect film consistent with bowel obstruction. Now an important question is how to differentiate small from large bowel loops on an abdominal X-ray. There are three things that you could assess to differentiate these two types of bowel loops. One is location, second is the wall appearance, third is the internal content appearance. Here's a different normal case with a supine abdominal X-ray. So let's start by the normal location or distribution of the bowel loops within the abdomen. The large bowels are usually located at the periphery. They frame the abdomen. And this here is the colon. The reason the colon is a little bit depressed here is because of the effect of the liver. Compared to the small bowel loops, which have a different appearance, and they are located in the center of the abdomen. Now, what about the content? Since large bowel contains fecal matter, it looks different than small bowel. Here's an enlarged image of the right-sided colon showing this mottled appearance within. So seeing this mottled appearance is consistent with fecal matter inside the bowel loop, and it denotes that this is a large bowel loop. Depending on the amount of air within the small bowel loop and on the patient's position, whether it's erect or supine, the appearance would differ. Here the small bowel loops do not contain that fecal appearance, the mottled appearance. The bowel loops would either contain clear air, such as what we see in this normal patient here, or in a supine patient where the fluid is dependent, it may contain this homogeneous higher density appearance. To emphasize the point, this is another patient who has constipation. You could see the large bowel in a peripheral location, and you see these alternating dark and white spots, mottled appearance consistent with fecal matter. If you see fecal matter within a bowel loop, you know this is a large bowel loop and it's not a small bowel loop. Finally, let's talk about the third differentiating point between small and large bowel loops, which is the appearance of the wall. In a normal patient without free intra-abdominal air, there is air filling the bowel loop, and that's why you see only the inner edge of the wall. But you could easily assess the appearance of the folds that arise from the wall. When it comes to large bowel loops, The folds are called hastrations, and these hastrations are incomplete. If you look at the folds of this normal large bowel loop, you're going to notice that it's incomplete, meaning that it does not connect or cross the lumen. Here's another large bowel loop as denoted by a mottled appearance in a normal patient showing an incomplete hastration. Now let's look at a supine abdominal X-ray on a different patient to compare the large bowel appearance with that of a small bowel appearance. The folds of the small bowel loops are called plica circularis or valvula conventus. If the small bowel is not distended, or even if it's extremely distended, it may be difficult to see those folds. However, in this mildly dilated bowel loop, you could see some of these folds and they appear complete. By complete, we mean they cross from one side to another, being completely circular. Here's another dilated small bowel loop in a different patient with an erect abdominal X-ray showing these complete folds. So remember that small bowel loops contain plica circularis, which are complete circular folds. Now going back to our initial abnormal case, let's decide what's small bowel and what's large bowel. There are distended bowel loops as we agreed on with fluid levels. This is the supine film showing this largely distended bowel loop which has incomplete folds consistent with large bowel. This is compared to these displaced bowel loops which have complete folds, plica circularis, consistent with small bowel. Our final teaching point is, what are the normal diameters for bowel loops? The guideline numbers are: small bowel should not exceed a diameter of 3 cm. Large bowel, except for the cecum, should not exceed a diameter of 6 cm. And the cecum, which is the most distendable part of the large bowel, should not exceed 9 cm. To remember this is the 3-6-9 rule. 3 for small, 6 for large, and 9 for cecum. Let's summarize what we learned today. First of all, evaluating bowel loops is one part of assessing an abdominal X-ray. Then, we decided that a supine film is good for bowel dilatation while an erect film is good for fluid levels. We also learned how to differentiate between small and large bowel loops depending on location, fold appearance, and content. Large bowel frames the abdomen from the periphery, contains mottled fecal matter, and has incomplete hastrations. While small bowel loops are usually central in location, contain no fecal matter, and have complete plica circularis. Finally, we talked about the 3-6-9 cm rule to decide on dilated bowel loops. That's it for today's case. Thanks for watching. Your comments are appreciated as usual, and see you later. The most obvious finding is this lobulated, well-defined soft tissue abnormality that's based on the pleura. Now, pleural thickening may occur due to benign or malignant causes. There are several benign causes such as previous infections, occupational lung disease, previous trauma, and others. However, there are features that are suggestive of a malignant etiology. The first feature is thickening that exceeds 1 centimeter, and this here exceeds that. The second feature is a nodular appearing thickening rather than being flat, and this here appears nodular and lobulated. The third feature is circumferential thickening, which is not seen in this case. The fourth feature is thickening of the mediastinal pleura here. So if you have any of those four features, even one feature, you should consider a malignant etiology. Now, once you decided that that's the case, you have four major possibilities. First, this could be metastasis, and we know metastasis could involve any location including the pleura. A specific metastatic entity that we're going to mention alone is metastasis from a thymic abnormality. The thymus, which is a normal structure that could be seen on CT, especially in young patients, could have several neoplasms, including thymoma. And thymoma, which is not the case here, is famous for giving drop metastasis to the pleura. So drop metastasis from thymoma is a consideration. The third possibility would be that of lymphoma. Don't forget, like metastasis, lymphoma could involve many places. Possibility number 4, especially if it's localized or continuous, would include mesothelioma, which is more commonly seen after asbestos exposure. This is a patient who does not have a thymic abnormality, is not known to have any primary malignancy, was not exposed to asbestos. When looking at the rest of the examination, you probably have noticed the fullness of soft tissues here. Every single rounded and oval structure here represents a lymph node, so this is left supraclavicular lymphadenopathy. There are other groups of intrathoracic mild lymph node enlargement, such as this para-aortic lymph node here. And this is not the only lesion that's based on the pleura. There's another one here. There's another one down here as well. So you have a multifocal pleural soft tissue abnormality that is nodular and thick with lymphadenopathy. As expected, the final diagnosis here was a proven large B-cell lymphoma. We learned from this case that pleural thickening may be benign or malignant. We also learned that you have 4 appearances of pleural thickening that suggest malignancy. These include thickening more than a centimeter, nodular thickening, circumferential thickening, and thickening of the mediastinal pleura. Once you see any of those signs, you have 4 big possibilities for your differential diagnosis. These include metastasis, thymoma, lymphoma, and mesothelioma. For you to remember this is what I call the 4x4 rule. Thank you for watching. See you with more cases next week.